Hey guys, welcome to Cosi Talks Live. Am I getting feedback or is it good? Nope, we started off all right. All right, guys, I got a really special guest with me in the Cosi Talks studio. I've got Dr. Joseph Hsu here sitting on that side of me. We're going to give you guys a minute or two to jump on board. For those of you who are watching the replay, thank you for doing so. Please give me a shout out, say replay, say hey Cosi, whatever. And if you do have any questions, go ahead and put them in the comment section, because after the show closes, I do go back to see those questions and answer those questions. So I'm going to go ahead and get things started on the Instagram channel. It's actually cooperating this evening. Yay. All right. So we are live on Facebook, YouTube, and Instagram. And I see a couple of you guys jumping on board already. So give me a shout out. Let me know who you are, where you're from, and what's in your mug. So you are technically at a conference right now, Dr. Hsu?
Yeah, this is a shot. It's a old shot from last year's our GECCO conference. It's a global collaborative congress on osseointegration. And so we're fortunate in Charlotte every year to host a group of surgeons, prosthetists, therapists, researchers, patient navigators, and patients from all over the country and all over the world to really share ideas and really break down barriers and silos, to really answer the questions, learn together and work together, really collaborate together.
No, I'm looking forward to it. I get to go this year, so I'm sneaking in.
You're going to have homework to do too. We're going to
I understand
the breakout sessions.
Am I okay? I was like, I'm leading one of the roundtable. I'm good at talking. I can talk, so that won't be a problem.
all you really got to do is get information from people and help lead us to some product. We're putting out, information statements and really define it. In the past, we've mostly defined research gaps that we've fed forward to different funding agencies. And then now we're starting to develop consensus statements about some, where we are now, what are the best rehab strategies for patients when they're at home and things like that. Mm-hmm. I think is one of the sections that you're in, but what are the ideal ways to set up alignment with our prosthetists and for patients with osseointegration? Because now you really can get very precise alignment.
Yep.
So those are some of the gaps that we're trying to say where we are today. Not to say that this is the answer, but this is where we are today, so that some researchers in the future, some surgeons, some prosthetists, some therapists in the future are going to figure out how to take us the next step when it's, GCCO 38 and I'm long retired.
Living on an island somewhere. That's living the
Probably
dream.
Right here in Charlotte still.
All right. Well, we got Ginny on board. There's my girl. Cheers to you, Ginny. Thanks for all your support. And she's got her ice cold glass of milk. We got Jill. We got Glenn. We got all the OI team here this evening, and I love it. We got Eric coming in from Chattanooga with his Pepsi. Dana, haven't seen you here in a while. I'm glad you're here with her. She's a right AK and drinking coffee. We got Randy coming in from San Diego with margarita. Y'all got some good drinks, man. I need to bring margaritas on the show next time. Next time you're on the show, Dr. Hsu, we're going to do margaritas. Let's see.
I've got the back to school bug, so I'm just drinking water right now.
Okay. No, and I got my copy right here. And we got Kim, Drew. We got a big crowd on board. All right, guys, we are going to go ahead and get started. Wow, lots of people here tonight. All right, guys, thank you. For those of you joining me for the first time, welcome. My name is Cosi Talks. I'm a physical therapist, amputee specialist, and the host of this show. I've been a PT now for a little over 23 years, and my passion is working with the limb loss community. With me this evening, I'm going to let Dr. Hsu introduce himself and tell us a little bit about what he does, because he's no stranger to the show.
Oh, thank you, Cosi. My name is Joe Hsu. I'm an orthopedic surgeon in Charlotte, North Carolina. I've been here about 11 years. I came here from the Army. I was in the Army for about 9 years, and really is where we started researching osseointegration. And went from being a skeptic early on in my career to really seeing the data and starting to see it turn and starting to see how it really could benefit certain people. And then some of my colleagues at Walter Reed really led the way with implementing what had been learned in Europe and other countries and bringing that in a sustainable way to the United States military community. And so I used those connections and went and learned from them to bring it to the civilian community for our concept is a for-all approach. We try and create a situation where people regardless of their health insurance, are able to get this done with our health insurance and make it doable in their own communities, whether that's us supporting their teams there or us, doing that surgery and supporting them more remotely.
No, and guys, he's not kidding. He has an incredible team set up and team approach at Atrium. You've been on the show. This is already your third time, I think, on the show in the hot seat.
I don't know.
But he's had a chance to tell us a lot more about the program over at Atrium Health. And I know some of you here have either been to see him or are scheduled to go and see him. So truly, you have one of the greats here sitting in front of us tonight. So thank you for being here this evening. So guys, we've done a lot of shows on osseointegration, but we are going to go a little bit over the basics of what osseointegration is. And then we're going to take a deeper dive into the statistics. I think probably one of the most hotly contested things I see on social media is osseointegration any good? Is it really improving people's lives? What about the infection rates? Is quality of life improved with all of this? So we're gonna dig into some of those numbers. And I'm actually looking at my stack of homework for the past 8 months of reading all the research studies. And thankfully, Dr. Hsu is gonna help me make sense of some of those numbers. So if you haven't been to one of our osseointegration shows, first of all, I do want to say a huge thank you to Integrum. They've been a sponsor of the Cosi Talks show, and they are a sponsor of tonight's show. They are the makers of the OPRA Implant System, which is one of the types of osseointegration. So let's just back it up a little bit. What does osseointegration mean? It's basically the melding of human bone with metal, specifically titanium. A gentleman by the name of Professor Brandemark in the 1960s discovered this ability for human bone to fuse with metal when he was trying to create the dental implant. And it's actually the dental implant that we use today. And then his son, Dr. Ricard Brandemark, became an orthopedic surgeon, and in 1990 he took his dad's work with the technology and implanted the first above-the-knee woman with this prosthesis, this implant, and it allows the person to use a prosthesis without having to use a socket. And we have a great video here that I'm going to let Dr. Hsu narrate as soon as I can figure out how to share the screen. Please hold. All right. It's here. I promise.
Well, it's funny that it's ironic that the implant, the predicate implant, is dental. My wife's a dentist, and when I was flying back and forth to Walter Reed learning how to do this stuff, she goes, "Well, I know how to do dental implants," and so
she goes, "I can tell you a little bit about how this works on a much smaller scale."
Yeah,
that's pretty cool.
But it is very interesting that the track record goes way back, not just for dental implants, but for bone anchored hearing aids and bone anchored facial prosthetics. And so there's a lot of information out there. But with the amputee care, it really goes back into the 90s with Ricard Brandemark.
Yeah. No, and he's now going on 30 years now.
Yeah. And that, to me, like I said, early on in my career, I was a bit skeptical because some of those longer term studies weren't yet published. And that's, for me, that's one of the reasons why we've used this implant, because it does have the longest track record and the most data to support it.
Okay, so I think I got this video working. Ready?
Yeah, anytime. And so this particular system is really done in a 2-stage surgery. And one of the things that we've done is try to compress the time between stages 1 and 2. And so depending on patient's bone quality, I mean, the on-label is to wait 6 months between stage 1 and 2. But for most of the part, we're waiting about 3 months between stages 1 and 2. There are certain select patients that have very, very dense bone where it's been safe to even shorten that time frame a little bit more between stages 1 and 2. And one of the reasons why we break that up, it's not just because that's how it's designed. You can pause it there. Is that also it really gives us an opportunity for the tissue to recover in between before we make that penetration site, which is really what this is all about. Regardless of the implant, the problem is the same. It's the penetration site and the risk of infection, which we're going to talk about later. You can go ahead and play the video. Okay. And so this is a depiction of a patient with a transfemoral amputation. And so what it first starts out with is widening the bone with a series of drills. And then this is a tap, which basically creates a thread form in that bony implant. And then we're able to put the implant inside the bone. And once that heals to the bone, and there's a little section that we use bone graft as well. Once that heals into the bone, after this would be the end of stage 1, then we come back after the wound is healed and it's shown to really integrate into the bone on x-ray. Then we'll come back at whatever that interval is. For us, it's typically around 3 months or so. And we'll come back for what we call stage 2. And at that point, we take off this little piece is called a healing cylinder, just kind of comes out of the middle of the bone. Then we create this muscle platform and a thin penetration site. And what you want is for this penetration site to adhere down to the muscle platform in the bone, so it really limits the motion there. So that when this abutment sticks out, there's really not a lot of motion around the abutment. And that's really one of the benefits of it, if you can really get that skin to stick down. And that's the biggest challenge that we have as a surgical team and as a rehab team, because that's really what helps protect the implant from late infection, because there's a lifetime risk of infection. This isn't just a surgical site infection like a total joint where you have infection around the time of surgery. Because of the penetration site, it's really a lifetime risk of infection.
Yep. And we're going to get to more of the details of that very shortly. So guys, there are more than one type of osseointegration. So since 1990, with the birth of the OPRA system with Dr. Brannemark, there have been at least 17 different kinds of OI that have been created, tested. Obviously, not all of them have been brought to market and used in amputee care. And there's 3 main big ones that we're seeing nowadays. We're seeing the OPRA system, which is called the screw fit, but because of the nature of how it looks like a screw and it's threaded in. Then there's the press fit. And for me, in my very simple-minded analogy, I think of the press fit almost like a thumbtack. So if you think of like a thumbtack or a bear claw, that's kind of like the difference between the screw fit and the press fit. And then you have something called the compress fit, which is being used more in the osteosarcoma. But you guys are going to see a lot of these different initials, the IPL, the ILP, the OPL, the compress, OTN, POP. These are all the different kinds of osseointegration, and they're not the same. And that's one thing I do like to kind of emphasize on the show, is the biggest differences are between screw fit and press fit method. And actually, we did a big old show on that with Dr. Doherty, I think it was back in May, where we talked about the different kinds and what are the differences. So I would encourage you to go back and look at that show. Okay. But just so you know, the screw fit, specifically the OPRA Implant System, is the only FDA approved in the United States and only for use in above the knee amputees. Now, some of you are asking, well, what about the people I hear about getting press fit in the United States? They're using what's called a compassionate device exemption. Or I always get those initials mixed up. Investigational device exemption. Thank you. And that's how they're starting to see a little bit more press fit in the United States. All right. So we talked about OPRA. So as Dr. Hsu mentioned, it is a 3-part system. It's the fixture, the part that goes inside the femur, the abutment, and then the axor that connects to the prosthesis itself. And he said it's a 2-part procedure. And globally, we are seeing it, though, used in above the knee, below the knee, above elbow, below elbow, and even thumb amputees. All right, so those are the basics. Those are the basics. But now let's get to some of the good stuff that a lot of people have been asking about, and that is infection. So before Dr. Hsu gives us some of these numbers, I want to kind of go over what does it mean with infection. And there's 2 main types when we're talking about osseointegration related infections. You have superficial and you have deep infection. Okay, superficial infection is just what the name indicates. It occurs near the surface of the skin, and it only involves the skin and maybe a little bit of the soft tissue underneath and near the implant site. Okay, people are going to get, and some people call it like a cellulitis, and some of you may have already had experienced this in just using a regular traditional socket. Okay, you have the redness, swelling, a little bit of tenderness, and maybe a little of discharge. The treatment is oral antibiotic and wound care if it's needed. Okay, so basically it means if you do present with a superficial infection, doc writes a script, you go, you take your 7 to 10 day course of antibiotics, and you're good to go. So Dr. Hsu, I know you have probably more to say about that than I did.
No, and I think that's it's very, very common to have a course of antibiotics. So if you really talk about, superficial infection, it's very, very common. And honestly, we have to really rethink the way we define infection. So if you have a bone anchored implant like this with a penetration site out to the free world, we know from previous studies that have been done in Europe that if you culture that site, it's colonized the overwhelming majority of the time. And what it is, the way that it works is your body kind of develops a local immunity and really almost a compromise with the environment. And that's how it works. We rely on your own good skin. Your skin is the largest immune organ of your body. And so we rely on that, and just patients to stay as healthy as they can and maintain reasonable hygiene. And in those situations, even if they develop a superficial infection, we're usually able to treat it with an oral antibiotic, and then get them back to doing what they do.
Okay. And just coming over to the audience here, we got some people. We got Carl coming in from Taiwan. Good morning to you, Carl. Susan asks, if it doesn't work for someone, can you go back to a socket, or are you screwed? No pun intended, I'm sure, Susan. And we're going to go ahead and we're going to discuss that a little bit more later on. Okay, so we're going to get to that question, Susan. David asked a good question. He says, how does the doctor decide which approach is best with regards to osseointegration?
Also a great question. At this point, we've only really used the screw-based implant. And that's really because we built a program to really help push insurance companies and different people to accept osseointegration. And so we wanted to use an FDA-approved implant. We do have a couple situations, the patients who really probably need a custom implant. And so that's something that's handled a little bit separately. But I think the main thing, at least from my opinion, I think a lot of it is not really about the type of fixation. It's more about the closure and the soft tissue management. And so if we can prevent that motion, I think that's really the most important part. And so a lot of the techniques, whether the technologies are the same, the techniques are starting to converge, where we're really trying to get a more stable soft tissue envelope no matter which platform we're using.
Okay. And actually, I had a little gift come in the mail today.
Yeah.
I got a toy. So I was sent this. This is basically the implant, the OPRA implant. And you guys can see that, sorry, I'm like not holding it to the camera correctly. You can see the threading there that is used. And essentially the skin attaches here, correct?
Okay. Yeah, and so that smooth interface is supposed to prevent irritation of the skin. There's been a variety of different things that have been tried with roughening the surface to get the skin to attach more, or leaving it smooth. And so we rely on the skin to attach very, very close to that abutment, right along the bone and the muscle platform there, so that it really doesn't move. And then that smooth surface to decrease the amount of irritation and abrasiveness that occurs with motion. Because one of the things that's new to patients that have this done, a lot of times they have hip flexion contractures, or if they're an upper extremity, they really haven't done much overhead motion. Then when they get an osseointegration, because we're anchored right to the bone, they can use the leverage of the prosthetic, either the practice prosthesis or their real one, to get range of motion they have just not had in our case, in some of our patients' cases, years. And so the more stable that interface is with that smooth portion of right at the penetration site, we think is what's going to help longer term. That's why a lot of that longer term data out of Sweden is pretty promising.
And it's very clean looking. I mean, this was something, and I've said this over and over on all the osseointegration shows that I've done, guys. You know, it's a very stark difference between what I see with the screw fit skin fixation versus the press fit. And we've had, a plastic surgeon come on the show and talk about how it's done. So it is a very different procedure. And my understanding is that this implant allows for that kind of attachment versus the other kind. So that's interesting. So we got questions coming in. Linda asks, wondering how you sleep with the screw sticking out, thinking one would catch it and it would bang on everything. Guys, I'm going to take an opportunity. I'm going to give a shout out to my girl, Jeannie. She has an amazing Instagram account and the handle is Slim Jeannie. And she really just shows what it is daily life is like with the OPRA Implant System. And she answers questions just like that, Linda. And I think pictures worth 1,000 words. So I think it's easier when you can see someone who's going through their daily activities there. Let's see. Kim asks, what about a person who was told she has nerve damage and cannot wear a socket? Is OI an option? Do you want that one, or do you want me to do that one?
No, I'm happy to do. I mean, you could do it as well, because as you know, dealing with nerve pain is a particular challenge. And a lot of the patients come to us, and some of their complaints are neurogenic pain. If it is pure neurogenic pain and they have a good limb, then probably what they need is a good nerve surgery. Mm-hmm. If other modalities have failed, by the time people come to us, they've probably done a lot of the desensitization work and the rehab work from that perspective. But with a combination of a limb that's hard to fit in a socket, which is about 20% of the time, about 1 in 5 people with transfemoral amputations really do not wear a socket. And these are young, active amputees. Yep. It is
20%. So that's 20%. 20% of above knee amputees are not using a socket.
Non-vascular, non-diabetic transfemoral amputees.
I mean, I know. Yeah. Go ahead.
And so if they have nerve pain and they have a limb that has not done well in a socket, then I do think they're a really good candidate for osseointegration. And we do the nerve work traditionally it's been done during stage 2. We've sometimes done it during stage 1. We call it stage 1.5. And the reason why we've done that is because we had so many patients with nerve pain up front. Yeah. That when we were doing it just as stage 1 and then coming back for stage 2, they spent months with an exacerbation of their nerve pain. Yeah. So really, more out of compassion, we modified a little bit the technique to do the nerve work up front. And so that is part of the process in it. And really pretty much the overwhelming majority of people who have had OI at our center have had some of the nerve work done. And that can either be RPNI, which is regenerative peripheral nerve interface, or TMR, which is targeted muscle innervation. And so I think we need to do some modern technique to the nerve, which has been shown to decrease neuronal formation and phantom limb pain, rather than the traditional way, which is called traction neurectomy, where you basically pull on the nerve and cut it. That's it. And that really doesn't give the nerve anything to do. And so if you don't give nerve's like a toddler. You don't give it anything to do, it's gonna wreak havoc on your home. And so that's exactly what's happening with unmanaged nerve ends.
Yep. And that touches on my second favorite topic to talk about with amputee. And guys, I've done several shows also on TMR and RPNI, and it's interesting to see both worlds coming together with OI and TMR. And that's a whole nother show for later. Yeah. Kim says she's presently in a wheelchair, damage done by injury. So Kim, there's the nerve pain that as to what Dr. Hsu described, but if there's actual nerve damage, meaning that there is a paralysis or a weakness in the muscle due to nerve damage, okay, that I think changes the scenario just a little bit, because then you're talking about whether or not the muscle can function enough to work through the gait cycle. Okay. So again, I've had patients who have partial spinal cord injuries, that they have a whole list of injuries, and the amputation is just one part of that. Mm-hmm. And we actually have a lovely lady on the show that she is, has spina bifida, and she's shared with us her struggles as well. So a lot will depend on what exactly is the nerve damage, what nerves are still functioning, and at what level are they functioning? Is it worth of a neurosurgeon consult to see anything about a nerve transfer or anything fancy like that? So I don't know if necessarily osseointegration is going to solve the nerve damage. It's not going to solve the nerve damage. And it's more about understanding what does she have available and how it can be used in the best way. Let's see. Dave Fink says, Dr. Shore's bundled my nerves and I have zero nerve pain or issues. And that's a really, and you hit the nail on the head. After TMR, a lot of people don't realize they're going to have a flare up once that nerve decides to wake up again, and it's going to be a flare up before it dies back down again. We've got a lot of questions coming.
There's a lot of questions. It's great. I'm trying to glance at the chat, but then listen to your responses at the same time.
New York Stock Exchange ticker tape. All right. Victor asks, how do I research the BK left lower with rod implant using rod as better anchor point for screw or press fit? My rod has been in 8+ years. The rod is only coming out. Major polytrauma accident occurs. Victor, can you clarify what your question is? I'm just a little confused as to what you're asking. and we'll get back to you. Okay, so let's go back to some of these numbers now, because we got to put some numbers here. All right, so with regards to the superficial infection, there was a great study done in 2019 by Dr. Brannemark and a lot of his colleagues, where they took 51 patients that they followed for 5 years. And guys, 51 patients doesn't sound like a lot, but in amputee world and in amputee research, that's a nice group, okay? Because we're talking about a very small group in healthcare population, and then within amputee group, a subgroup of folks who had osseointegration done, okay? So out of the 51 patients, 34 patients had a total of 70 superficial infections over the course of 5 years. Okay, so when you balance out all these crazy numbers and statistics, basically it was saying like once every 2 years, a person could expect to have a superficial infection that would need treatment. And again, going back to what Dr. Hsu said, it would involve a course of oral antibiotic, and then they went about their day. Okay, I think Kurt said on the show once, it's like the incidence of you getting the flu once every 2 years. Okay, so I
think it's very common, and it's been published with in the German literature as well, with a German implant as well, about the penetration site colonization. I do see a second question about a fusion nail. I saw that come up earlier.
Go ahead.
It sounds like a patient that has stress fracture or fractured the tip of a knee fusion nail. It's certainly possible. Periprosthetic fracture happens about 6% of the time with an osseointegration. There's probably a little less stress on an osseointegrated implant for prosthetics, really mainly because of how the prosthetic works itself. And there's usually, most of them have a fail-safe type of a mechanism. The one that we use does. And so that fail-safe, rather than having all that stress go through that abrupt change in stiffness from a instrumented metal part of your bone, like the knee fusion nail, to a non-instrumented part of the bone, rather than have the stress at that interface, the fail-safe mechanism will actually release. And it did. There's a picture of him later in the presentation. He got bucked off a horse, and he said he landed on the ground. He's looking at his foot like this, so he figured his leg was broken. But what had happened is the fail-safe gave way.
No, and that happened to me actually at the Amputee Coalition conference. I was working with one of the guys from Integrum, and all of a sudden he just twisted a certain way, and we're like, what just happened to your knee? And it finally hit me, the safety mechanism. So guys, that really is a great feature, and I kind of want to just be a nerd for a moment there. So, one of the biggest things is when you fall, right? It's because your knee buckles, right? That's one of the very common ways of falling. So obviously that's when you would be at a higher risk for a fracture. So what happens with the safety mechanism is the axor, that part that sticks out and connects to your knee, it allows that knee to give more. So it gives at that part instead of at the actual implant itself. And it's a safety mechanism for flexion, so bending the knee too much, and also rotation, guys. So the whole planting and cutting and doing a fast turn, which is what happened to that guy at the Amputee Coalition conference. And then the neat thing about the OPRA system is the patient can reset it themselves. So if they trigger that safety mechanism, they basically just sit there and they do their magic, and it goes back into place, and they go about using their leg. With the press fit, they have to go back to the prosthetist to get it reset. So that was my nerd moment right there. Ooh, this is actually a question. Audrey asked, I cannot wear a socket due to CRPS, complex regional pain syndrome. Have you had any patients come to you for that? Are they candidates?
Yeah, for us, I kind of talk about nerve pain in a little more general terms. I know that there are different categories that people talk about and try to classify it down. And I appreciate that, and I respect the science behind that. But I just try and keep it very simple for patients. And so I think what happens with whether it's complex regional pain syndrome or neurogenic pain or causalgia or whatever people want to call it, I think what happens is you cannot extinguish neurogenic pain until you get rid of the mechanical stimulus of pain. I think that they are closely related. And I really learned this through working with limb salvage patients in the military. We created something called Return to Run Clinical Pathway, where we did carbon fiber bracing for people with limb salvage. And what we saw is that their pain extinguished their neurogenic pain extinguished when we protected their mechanical pain. And I think we're doing the same thing with osseointegration with patients that have a complex regional pain syndrome that are in a socket, because every time they put on the socket, they get a mechanical stimulus that is either injurious or it just triggers the neurogenic pain. And there's really not a way to get through that unless there's some way you can bypass that negative stimulus. And that's one. So if you decide on OI, number one, you need to have nerve work done at that time. And so either targeted muscle reinnervation or regenerative peripheral nerve interface. And then anchoring directly to the bone, it prevents that stimulus of the soft tissue that keeps that going. And so I think that it is a potential benefit, but it's something to really enter into carefully. And I think you have to develop a trusting relationship with the team and say, look, they do understand this. It doesn't go away right away, but it can over time. And here's the reality, though. There are new and interesting things that you're going to find out about the challenges of being a patient with an amputation with osseointegration. And so there's no free lunch to a certain extent. There are challenges with it, but I think for people that cannot wear a socket and can't ambulate, it is really a life-changing situation. And we had several patients that spent years being unable to ambulate that are doing so now.
Well, it sounds like one of the guys here, Ron Ritchie, he said, Cosi, I was Dr. Hsu's first OI patient, and it changed.
Number one.
It's the best.
So how many?
So there's the proof.
How many have you done? And it says 0. As a matter of fact, Ron actually wrote a letter to our leadership of our health system to really help us get it approved, because that's one of the challenges is each of the teams that does this, they have to get it approved in their hospital and their health system just based on how new it is and the cost of the implant.
Yeah.
And reimbursements and things are far behind where the technology is right now, and so it's a challenge. So thank you, Ron. You helped launch this for all of us.
All right, so getting back to the big bad wolf. So we talked about superficial infection. Now let's talk about deep infection. Okay. And again, that's going to go a lot deeper. It's going to be affecting the bone or the implant. And at this point, we call it osteomyelitis, right? The infection is more severe and can lead to very serious complications, including sepsis and death if left untreated. So the symptoms are kind of like the superficial, but just souped up. So severe pain at the implant site, fever, chills, persistent purulent, which basically means disgusting stuff coming out of the drainage site, and a high bacterial count when they take a blood test. The diagnosis is typically done with a biopsy or a culture of the area, and sometimes even with X-ray and MRI if it's an extended infection. The treatment includes IV antibiotics. So the oral antibiotics will not work in this case. It's usually 6 to 8 weeks in general, depending on how bad the infection is of IV antibiotics, surgical debridement, and possible removal of the implant. So just going back to that study that I talked about in 2019 with Dr. Brandemark, that out of the 51 patients that were examined and followed for 5 years, 11 developed deep infections, and one of them had to have the fixture removed because of the infection. Okay. And then I put in another study, and guys, I have all these studies. So if you guys are nerds like me and you like to read research studies, a lot of these, you can find them online, and I'm happy to send you the link to these studies. So the Tillander, there's another study by a guy called Tillander in 2016, and it looked like 96 patients, and they had 102 implants. Obviously, some of them had bilateral implants, and they found osteomyelitis in 16 patients. So just to make these numbers a little bit easier, it comes out to a 10% chance of developing osteomyelitis, or otherwise known as a deep infection. So Dr. Hsu, I know you got thoughts on this one.
Yeah, I mean, the first thing is to applaud the authors for publishing honest results. What I try and teach people is that if you're going to innovate in a space, you're obligated to publish it. And it's the reason why all of our patients here are part of a registry, and we're actually looking at some of that data now and publishing that. And we actually have a supplement that's going to be published here pretty soon. The deadline was earlier this week, where we're really, a lot of that is really consensus statements and identifying gaps for future research. And so the authors for this were part of the original cohort out of Sweden, and they published longer term results on this and really focused on the biggest risk that we have, which is infection. When I counsel patients about this, I don't really give them percentages anymore, because I think we think about things like, if I tell someone, you have a 20% chance of a deep infection.
Doesn't sound too bad, does it? But
right, because I think 80% of the time I'm going to be great.
Right.
But then if you think of it as a 1 in 5 chance, so for every 5 patients, and I point to my clinic hallway, I have 8 rooms. I said, so for this part of the hallway, if there's 5 people in here, one of them has a major deep infection, and I tell them that goes to the bone. And I try to be very simple with it. Not that patients are uneducated. As a matter of fact, the osseointegration patients that seek care with us are some of the most educated patients I've ever seen. They come in and they know about materials, they know about the research. I mean, they've been connected through communities like this. They're very well read, but I want them to hear it so that it resounds in their minds, and their family hears it as well, in very simple terms. And I said, so 1 in 5, you're going to have an infection that goes all the way to the bone. Now, we have treatment strategies for that. And some of the stuff that we're doing, some of the treatment strategies that we're using, we're going to be publishing on soon, and hopefully going to get a grant from the Department of Defense to really help through our global collaborative network to use some of these implant salvaging techniques, because we have been able to salvage implants that have had infection all the way to the bone. And then, as far as the explant goes, I tell them 1 in 10. I said 1 in 10 is, and the thing that I tell patients, and when I tell surgeons that want to do this, I tell them this: if someone says to you that my infection rate is lower than the published literature, I'm concerned that they're disingenuous, and I'd probably get another opinion. What we're seeing in Charlotte is really no different than what is in the published literature, and I have had to take out implants as well, and for the most part, the patients that we've taken out the implants, one has already been reimplanted, another one is waiting to have his reimplanted, and the other was fairly recent, and so I think that if people are going to tell you I'm doing better than what's out on the science, I'm very concerned about that.
And guys, I'm going to interrupt for a second, because Dr. Hsu is going to be way too modest, so I'm going to say it for him. But if you were to have a conversation of who are the top 5 surgeons in the U.S., and I would extend it even a little bit more than that outside the U.S., his name would be in that list for sure. When you talk about the top 5 surgeons doing OI in the United States, Dr. Hsu is on that list, right? And, I don't want to call it's the nature of the beast, but, it is an invasive surgery at the end of the day. And you are implanting a foreign object into the body, and you are leaving an opening there. Okay, so that is the stark truth. And you guys know that on this show, I don't sugarcoat things. We talk about the good, the bad, and the ugly. And it's not to say OI is crazy and nobody should ever do it. No, we've seen some of the amazing benefits, and we're going to talk a little bit about those statistics in a minute too. But it is something that you need to go into with your eyes wide open, and you need to decide if the pros and cons of living with a traditional socket outweigh the pros and cons of osseointegration. And that when people come and ask me, should I get this done? That is the first thing I ask them is, what is it that you want to be able to do with OI that you cannot do now with a traditional socket? And how is it going to improve the quality of your life? And then educate yourself on what it is that you potentially will have to deal with. So Dana asks a very good question. So what are the best ways to prevent a deep infection? It's a little scary.
Yeah, I mean, I think the things that patients can do, and I have to tell you, one of the patients that we explanted was doing great, model patient, doing all the things right. He was healthy. He was fit. He was non-obese. And it was years later that the infection came up. But what can we do? We can mitigate that risk. And so good hygiene, and a lot of the hygiene is just the normal, I call it normal human hygiene. Soap and water, keep it clean. If you're going to go into a rough environment, do the best that you can. I mean, obviously we have patients out there on horseback, and I said, please go buy some baby wipes from Costco or Sam's Club. I have no disclosures with either of those. And try to keep it clean as best you can. If you can't, do daily showers, etc. And, if people can stay fit, I think that that's important. We have BMI cutoffs to qualify for the surgery. And we've had patients that have continued to lose weight. We've had other patients that have gained weight, which can contribute to challenges. And then life happens, right? People develop diabetes, or diabetes gets exacerbated, or we've had patients that have had a cancer down the road that was, unrelated to their limb. Life happens. And so there are situations that are beyond their control that happen. And then probably the number one modifiable risk factor is smoking. And
Yes.
and so and here's the reality: it's smoking anything. It's the carbon monoxide is probably the bad actor. Nicotine gets to blame, but there's basic science data that probably nicotine is less the bad actors is the carbon monoxide that comes with combusted, inhaled substances. And so whatever that substance may be, substance of choice, no judgment around it. But, I don't want to get on a cannabis discussion, but it's a 5 to 10 fold increase in carbon monoxide level over tobacco smoke. So it doesn't get a free pass.
I had no idea it was that much more than tobacco smoke. So basically,
Carbon monoxide is what we're worried about. So I tell people, look, use nicotine patch, use some other kind of way, eat it, consume it, whatever. But the number one modifiable risk factor, in my opinion, and based on literature that we have mainly from other areas of surgery, is smoking.
Yeah, no, and I can tell you horror stories of the past 23 years of working surgical floors of the people who smoked and the people who didn't smoke and who had successful outcomes. Let's see. Dave says, as I said, Cosi, I had a deep infection after stage 2. I had 6 weeks IV antibiotics 3 times a day. Perfect now and well worth it. I always get updated pictures from Dave, living a very full life with his OI. Dave says, I know that drill went well to the bone when you are 1 out of 5. Jenny's saying, agreeing 100%. The whole team at Atrium is top notch. Let's see. Linda asks another very good question.
Can I jump off that comment, Cosi? Yes. I mean, I get very uncomfortable when people talk about me as a surgeon and things like that. The reality is I've been very fortunate to surround myself with an incredible team. And I think and that's what I try and teach people is that's where it really comes from. We can stay on top of problems really because the team is in constant contact with our patients. Our navigator is excellent. My nurse is excellent. And everyone knows, therapist, my PA, and any touch point, everyone on the team is notified what's going on. And here's the thing. And this is what I tell teams. If you're going to do osseointegration surgery, you're married to that patient.
Yep.
So this is not it's not for the faint of heart. It's not a one and done procedure. If you want to do one and done, then put in a total joint that's going to last 20 years and has an extremely low infection rate.
Yeah.
That's not this. And even for our patients that have had hip fractures that fell, and they have hip fracture it's in the same limb, but it's not even close to the implant. People don't want to. They don't know what to do with it, and so.
And that is something, unfortunately, I do hear about. And for me, guys, whether you go with the press fit method or screw fit, I obviously have my preference, but it's making sure that you have vetted that surgeon out and their team. Because Dr. Hsu is absolutely right. It doesn't matter how good of a surgeon you are. If you don't have that team around you, your patient is not going to succeed. And we've heard, unfortunately, a lot of cases internationally and also even here in the US sometimes where that's happened. So yeah.
There's a question about cancer as well. It's for whether you have an unrelated cancer or not. If your cancer is stable, so if you have a resected cancer, you have a treated cancer, and it's stable and you're in remission, then it's something that we go through all the risks and benefits of it. And it's something that can be done. Obviously, these are done in patients that have orthopedic oncologic diagnosis. So they have an orthopedic cancer, and that's why they had an amputation. But if they're in a stable situation, they can have an osseointegration. And if they, like I said, some of our patients have had a cancer at a remote site just because life. And we've had people that have undergone various cancer treatments with an OI implant in and made it through.
They did it.
So, of course, we hold our breath when they're undergoing chemotherapy with an OI implant sticking out of their skin. But, all we have is anecdotal reports, which is why we need to work together. All the centers need to work together regardless of the implant, because we're never really going to be able to give a scientific answer for a question like that if we don't work together, because each of us has had one or two patients that have faced a struggle like that. And so we've got to be able to work together to answer that.
All that data together. Guys, I realize I'm always like halfway through the show. We still haven't done our giveaways. I'm like, ooh. Jamie gonna be so mad at me. No, I'm kidding, guys. All right, guys. So I love my giveaways. And again, thank you to Integrum for sponsoring these giveaways. I have a Integrum t-shirt coming to the person. I'm gonna go ahead and I'm getting fancy this tonight. I have a QR code that leads directly to the Integrum Facebook page. All right. On that Facebook page, you are going to see a very cool picture, and I'm looking it up right now so I can see who's going to be the winner. A very cool picture of Dr. Hsu himself, the man.
I'm not sure I'm on the Integrum. I didn't know. I'm not as good at social media, so.
All right, so I'm on it. I'm on there. All right, there's a great post with Dr. Hsu there, and he talks about how cool tonight's show is going to be. All right, you guys need to follow Integrum on Facebook, like the post, and I'm going to pick the winner from the people who liked the post. So go now and right click. Don't click out of the show. Do the whole right click thing. All right, let's keep talking. All right, hang on. I got so fancy that now I don't know how to take this thing off. All right, we'll leave it up for just another minute or so. All right, so and then I do want to kind of just reiterate a little bit again, guys, with some of these studies, sometimes when you read research studies, you go, okay, well, who's writing the research study, who's running the statistics, and who's running the numbers, okay? So when you look at these numbers, as Dr. Hsu said, it's a sobering number. It comes out to 1 in 5 people will require, they have a deep infection. And what was the statistic again of somebody having to have it explanted?
It's 1 in 10.
1 in 10,
yeah.
Okay? Those numbers, make you pause. And the man who invented this whole procedure published the study. Okay, so he did not hold back. He didn't try sugarcoating any numbers, and he put it out there. And what was really cool is I got to read studies from 30 years ago, because since OPRA's been around the longest, they have the most amount of studies out there, right? And just kind of reading through the literature through the years, you can see how they've taken the mistakes that were made and they've improved upon it. And you see that progression in the literature. Okay, so where they were 30 years ago as to where they are now. And it'll be very interesting to see where just in even 5 years things will be. All right, guys, I see a lot of you clicking on the QR code. That's so much fun. All right, hang on. Please hold. See, this is why I need Jamie, because I really stink at doing social media when I'm live. I am no good at this. All right. Random pick, Lisa. Lisa Chacon. All right. Congratulations, Mama. You are a winner. So here's what I need you to do, Lisa. I feel like I'm running a 3-ring circus. All right, here we go. I should be used to that, right? All right, Lisa, there is my email address. What I need you to do is I need you to send me your address and send me your t-shirt size, and we will send you your Integrum t-shirt. Guys, don't worry. We've got 2 more winners that we're going to announce this evening, and I'm not going to forget. I promise, Jamie, I'm not going to forget. All right, but let's go back to, let's talk about some of the more, oh, wait, that was the question. That was another question that was asked. So let's say, worst case scenario, someone has to have the implant explanted. Then what? Can they have it re-implanted? Do you see that they want it re-implanted?
Yeah, so we've unfortunately had to do that, and we knew that it was coming. Just because like I said, the numbers are the numbers.
Mm-hmm.
So what we'll do is if they have it explanted, we try to have them go back into a socket for a little while. There typically is enough soft tissue to go back to a socket because, you know, as everyone knows, the ischial bearing sockets, you really don't put quite as much pressure on the end because that muscle coverage over the end is pretty much gone at that point. But we've been able to get people back into a socket for some period of time, making sure their infection is clear. And so the way we do it, we remove the implant, we put an antibiotic cement spacer inside the bone. They're treated with antibiotics until they're showing no more signs of infection. And so we'll do inflammatory markers. If the inflammatory markers are normal, then we'll talk about whether or not to go back with another implant. If the inflammatory markers are not normal, then we'll typically get another MRI to see if there's any residual infection. And if there is, then we'll go back to surgery again to help manage that infection, get rid of that, another round of antibiotic spacer and antibiotics. And then if all that clears up, then we can come back with an implant.
And then I really wasn't able to find a good study that indicated this, but just from your anecdotal practice evidence, you know, do you find that patients want to have the implant back in, or are they saying, no, you know what, I'll just go back to using a traditional socket?
You know, I think that decision we make over time together. I think initially when people realize they have to take it out, they're really crestfallen because, I mean, they went from not ambulating to ambulating. And so they say, I want it in right away. And then there's another period of time after they start getting up in the socket a little bit where they kind of are not sure. And I think they have to kind of go through the socket phase again to decide, you know, is it worth the risk for me to go back again? And so, you know, I think that with the few patients that we've done this with, it's a decision that's evolved over many, many months to go back to an implant. And so we'll see how that goes. And again, I mean, we'll not be able to write that timeline for people until we have centers that are collaborating, so we can say these are the patients that got replanted. This was the average time to reimplantation. These are the reasons that people wanted it again.
So again, Susan, I think it was Susan who asked that question earlier because she said, you know, can a person go back to using a prosthesis, or are they screwed, in her words? So yes, there's your answer right there, that you are able to go back to using a prosthesis. And then there was another question by Van Gregory asking about the activity level and what is allowed and not allowed with OI. And I know Van Gregory, he's like, he actually kicked my butt in a 5K at the Empower Fest. He's our bilateral below the knee phenom on the show, and he does everything. So I would say that is probably the main limitation with OI, is not able to do high impact activities. So if you're a runner, if you are jumping rope, that's probably not the course of action for you. But you know, what are your thoughts, Dr. Hsu? That's pretty much a hard stop there.
Well, we're learning, and so one of the talks that we're going to have at Gecko this year is on impact sports after OI. There are some European centers that have done it and even talked about it. We have selective patients that have done it. So the problem is we don't know what we don't know at this point. And so the official recommendation is no. But you know, I was on active duty during the war for a long time in the military, and I told the soldiers a lot of things that they shouldn't do, and they did them anyways.
Yeah.
What it did is it actually progressed us, and it progressed the way that we thought about things. And we've since subsequently done research on that, like our early weight bearing protocols for some of our fractures in limb salvage patients. We treat patients very differently now because wounded warriors, they say, I feel good, I'm going back. And they went back to high level activity before we were comfortable with it as a healthcare team. And so following those people, we started to feel a little bit safer about doing some more advanced protocols with, you know, gravity limited treadmills, and, you know, we started doing more blood flow restriction and things like that. And so I think that the patients are going to teach us what we can do and what we can't do, and whether it's good, bad, or what the limitations are going to be before any official recommendations can change. But as we learn this stuff, I think we're obligated to publish on it too and say, look, this is what people are doing. These are the activities that people are doing with these implants without making the official recommendations. And then we'll grow towards where we can educate patients just like you just did with real numbers. These are the numbers of patients doing this. These are the numbers of patients that. This patient had a complication from, whatever.
That's definitely a talk I will be sitting in on in November. I'm making my list right now. Kim says, this has been a very informative and understanding way. Thank you, Kim, very much for saying that. So guys, let's talk a little bit about, some of the positive statistics, because there are a lot of positive statistics with regards to OI. All right. Why would you have OI done? Is this your cowboy you were telling us about?
That's
right here.
Yeah.
No, and it's interesting. I had like the past 3 weeks on the show, I've had several people who enjoy horseback riding. And I think one of our ladies is here this evening. So we were talking about horseback riding. So that's why I kind of picked those particular pictures to show off. So guys, what are the benefits of OI? Number one, you don't have to use a socket. And let me tell you something. I love what I do, but it is a pain in the butt as a physical therapist having to teach a patient how to use a socket, because there's so much going on with limb volume change, sock management, skin breakdown and issues there. The inability of a socket to allow the person to really use the muscles in their leg. Okay, so for me, just from a PT standpoint, my selfish PT standpoint, I love the idea that the person's thigh musculature is not going to be restricted anymore. They're going to have to work harder because they're going to have to strengthen the things a lot more, but they're going to have so much more range of motion available, so much more hip extension when they're walking, the ability to really use those glutes and whatever is left of their hamstrings and quads. I mean, it's just that part alone. All right, a lot easier to don and doff. So basically it takes all of like 10 seconds, 15 seconds to click on the prosthetic leg, something crazy like that. And guys, there's a whole plethora of videos on my YouTube channel, on my webpage, on the Integrum webpage, where you can see people just clicking it on and off. And those of you who are my AKs out there, I know you're kind of groaning right now because you know what it's like to have to put that liner on. And if you turn it even 2 millimeters to one side or the other, and you got to take everything off and start all over again. Being able, we talked about the more normal gait pattern, easier to sit down. You're no longer chipping the toilet seat with your socket as you're sitting down. And then probably one of the coolest features, in my opinion, is osseoperception. So you all hear me, my favorite terminology on the show is the terminology of proprioception, your ability to know where your body is in space, right? So because you're getting all that feedback right through the center of that bone, okay, you're feeling where your foot is now. And that's probably something I hear. If you talk to anybody who has OI, they'll open their eyes and go, oh yeah, you can really feel where you are at that point in time. Let's see. Anything you want to add to that one, Dr. Hsu?
No, and some of the slides you skipped over for the sake of time really go through the improvements in some of the physical performance measures, the time that people are wearing their prostheses as well. I think that's one of the biggest things, that this bottom line is where people are going to wearing, 14 hours a day as opposed to 8. And so, an 8 is a good, that's someone who's doing well on a socket. And so, that's kind of the hardest, challenge, is risk benefit for someone who's doing pretty well in a socket if they're wearing it 8 hours. I'm sure there are people on this that are thinking, I can't wear a socket 8 hours. And we've had people on here that also commented that they can't walk at all and can't wear a socket at all. And so you can imagine it is completely changed the way that we're able to treat patients like that, to be able to do this. It's interesting that you talked about sitting on the hard surface. The only reason why I bring that up is I've learned that from my patients. How would you know, as an orthopedic surgeon that does not have a transfemoral amputation, what a barrier that is in life? And so part of this journey has been incredibly interesting to learn a lot of these things. One of my patients taught me, you can't ride an upright bicycle anymore because your leg falls off. I didn't even think about that. So this has really been an interesting journey over the course of the past 5 years to learn as much from my patients as, we're supposed to be the healthcare professionals teaching them, but a lot of times we don't even know what the gaps are because they spend more time with the therapists and the prosthetists than they do with the surgeons. And so it's been really interesting.
Yeah, and it really is the little things in life. I think a nurse, when I worked the spinal cord injury unit, she goes, the biggest thing in quality of life is just being able to use the bathroom. When you work a spinal cord injury unit, you see that in your patients. With amputees, same thing, the toilet seat. Just simple things like when you're out in public and the suction comes off your leg. No matter how well that socket is made, that's going to happen at some point or another. And either you get up and you fall down, or you're making weird noises with your socket as you're trying to get back in there, tearing
Right.
up your pant legs all the time. It's little things, but it's these little things that, it becomes a part of your daily life and things that we take for granted. So yes, and that study, it's actually a really great study that you just referenced right there. So going from 8 hours a day to 14 hours a day. And in this particular study, it was interesting because it did not compare those who used traditional sockets versus OI. It was comparing people who used traditional sockets and then had OI done.
Correct.
So it was comparing the before and after picture. And Dr. Hsu, in our pre-interview, you talked about the importance of having that kind of information.
Yeah, I think that's the information that's more important to me and to the patients, right? Because you can compare one patient to another and you're going to get a different wear times and different performance, but same person, different wear times, different performance based on your interface. Because this is what's happened, right? And this is what happened as really, not only a result of the natural evolution of technology, but the leap forward that occurred after Operation Iraqi Freedom and Enduring Freedom, after these wars in Iraq and Afghanistan. Technology pushed so far forward in prosthetics that the interface became the issue. It's no longer what can be accomplished with the prosthetic. It is the interface. And so the socket became what we started to look at. Now, if people are high performing in a socket, and we have many of those, many high performers in a socket, and we just finished watching the Paralympic Games, and you can see people doing things that, I've never been able to accomplish on my best day. Those are probably not candidates for OI, really mainly because it's about risk benefit.
Mm-hmm.
So if that benefit becomes more narrow, then the impact of the risk becomes greater. It's the patients that really are struggling to wear a prosthesis at all, or can only wear it for a short period of times. Or like one of our patients is an avid hiker, and one of the things that he would say is, well, I wouldn't wear and he's a transtibial, I wouldn't wear my socket for a week or 10 days before I'd go on a hike, just so I could save my skin. And then I would go on a hike and then I couldn't wear it for another week or 10 days after. And yeah, otherwise reasonably active, but to do what he wanted to do. And so he's one of the few transtibials that we've done here at our center, which brings up one of the questions I saw in the chat about, it's only FDA approved for femurs right now, this particular implant. And it's all about how the FDA works and the level of evidence required to get FDA approval. But there's a compassionate use mechanisms you can go through. You can use it on the tibia, really as a physician-directed use. But for the humerus, we've done several humeruses, and we even have a thumb upcoming. Those are done through a mechanism called compassionate use. And so you actually have to take all the patient's information, and then you work together with the company, you submit to the FDA the reason why we would want to do that for the patients. And I hope in the future that the humerus is going to be FDA approved in the near future, because it's completely different for the humerus to take away suspension completely and anchor right to the bone.
Game changer. Not to mention the technology the neural interface that you can attach to that is kind of insane there too. So Harsh, I hope that answers your earlier question when you were saying as a BK, you're walking around for 14 hours a day, then, this would not necessarily be a candidate for OI. So with this study, it was basically acknowledging like, yes, there are people that are already very high functioning and that they are living their lives and they're not going to be a candidate. But for the people that are struggling, this is what it can do for them. And then there's one more set of statistics numbers I'm going to throw at you guys. And before I do, let's go back. So guys, one more giveaway. And I don't have a QR code, but basically you just go to the Integrum on Instagram. Same thing, guys. You're going to see Dr. Hsu's smiling face. It's under you're a popular guy at Integrum USA. All right. You are the Vanna White for this evening. So guys, that is the Instagram handle for Integrum. So go there, follow them. I'm looking at the numbers, so I'm looking to see if you're actually following them or not. So, keep it real. All right. And then go to that post with Dr. Hsu and like that post. I will be choosing a $25 gift card winner. Yay. And guys, for the YouTube, giveaway that we had prior to the show, we've picked a winner. It's a handle. So I got to go hunt down that person and let them know they also won as well. All right. So guys, go to the Instagram, follow them, hit like on that post, and I'm going to pick someone to win. Oop, finally, numbers are ticking up. Yay. I'm going to find somebody to win a $25 gift card. In the meantime, let's put up some of these numbers again. All right. So guys, in the world of studies, we have 40 million different surveys that we can give patients. Sometimes it's surveys that the clinician does on the patient. They're all called functional outcome measures. You've heard me talk about them on the show, like the AMP Pro, the AMP No Pro. It's basically standardized tests, and it can test anywhere from balance to gait to fitness level to standardized testing for depression screening. So the one that we kind of pulled upon, it's called the QTFA, and another one called the SF-36. And what you really need to know, especially about the SF-36, this one's used all around the world. I was actually reading a study just today where a Spanish clinic that works with amputees used this to screen their patients, and is basically testing quality of life. Okay, and as the number indicates, there's 36. There's a lot of things that they're asking the patient themselves, but basically asking them, how do they feel about their health status? How do they feel about their body image? How do they feel about their mobility? It's all about how the patient perceives their own quality of life. Okay. And all the patients took the test before having OI and after OI. All the scores went up. Okay. A lot of these scores went up. Okay. There's another test here, and this one was done by another study done by Dr. Al-Mudaris, and he is the creator of the PressFit system. And he did a study, and I believe it was on PressFit and ScrewFit. I'd have to go back and look at that study, but he did what's called the 6-minute walk test. Some of you have done that test. I've given you guys some of this test myself. Okay. And it's basically how much can you walk in a 6-minute time frame? And you can see the numbers right there, 286 meters to 512 meters. That's a lot. That's a huge jump. Okay. In the ability to walk. The timed up and go test, also known as the tug test. Many of you are probably familiar with that test because your PT's probably sacked it on you at some point or another. It basically times how long it takes you to get up from a chair, walk a certain distance, walk back and sit down. Okay. And you can see the numbers right there in front of you, from 13 seconds down to 9 seconds. That's a lot in amputee walking time for that to go down. So these are some of the scores from after osseointegration. All right, Dr. Hsu, do you have any? I mean, those are a lot of the PT numbers that I just threw out there.
And so the QTFA is specifically for amputation patients. The rest of these are scores that we use in all kinds of, and not only orthopedic diagnoses, they're used in, to test patients with cardiovascular disease and improvements from different interventions. And what you typically see, and there are published what they call MCID, minimal clinically important differences, and they're usually small. There are a few points here or there make up the minimally clinically important difference, which means, is it important to the patient? And the interesting thing about these numbers are massive. These differences are massive. They're not just statistical findings. These far, far exceed several-fold the numbers that we've determined are meaningful to patients. And so it's really interesting to see these, especially the bottom ones that we do in a lot of other conditions, where we're hoping to if we gain a few meters on the 6 meter walk test, we consider it a win. And time up and go, if you change that by maybe a second or so, we consider that a win. So these are massive.
Yeah,
massive.
These are huge numbers. Huge numbers. And any of you who have taken that test, you can appreciate this as well. All right, we got our next winner for the Instagram $25 gift card, Rick Cooley. Congratulations. I'm putting my email address up there. I need you to email me your address so that we can send you your gift card. All right, so we do have a question here from Trisha. Yes, Trisha. She says, I've never been able to wear prosthetics since I lost my leg 5 years ago. I've had TMR surgery twice, 2 revisions to my amputation. Would OI be something I could pursue? I am an above the knee amputee. So Trisha, I am going to put out the website for Integrum. And actually, I have another QR code. Aren't I fancy? All right. You get a break tonight from this one. This one's Dr. Doherty's QR code. But no, guys, if you check out, this is from when he was on the show in May. So guys, if you click on this QR code, and I can see some of you already doing that, and thank you, you can find an OPRA surgeon near you. Okay. And again, guys, if this is something that you're contemplating, do your research, and it kind of starts with this show. So thank you for thinking about that at this show. You have my email address, so I can put you in touch with people to see about having a consultation done. If you go to the Integrum website, which I need to go find that so Jamie doesn't get upset with me, and I'll put that up there. They have a form for screening, and they also have a chock full of information that you can learn about. Sorry, guys, I'm like trying to copy and paste this website. So Dr. Hsu, why don't you tell us a little bit about when someone comes to your clinic asking about OI, what is the process that you take them through?
Yeah, I mean, they'll typically contact either my nurse or our patient navigator early on, and they'll get scheduled in. It depends on where they live. If they live nearby, I just have them come to clinic to see me in person. If they're a little bit further away, we do a lot of virtual visits just to give people information. Obviously, if they live out of state and I'm not licensed in that state, I can't give any medical recommendations. We just tell them about our program. So it's an informational session. It's a no charge visit. And they just learn a little bit about, our program and what to expect. We talk about the two-stage process, the rehabilitation process that we do. And who the other people are that they would want to meet on our team. And then if they decide to proceed, then we'll have them visit us. They'll come to Charlotte to meet with me. They'll meet with our physiatrist, our physical therapist. We have a dietitian for people who need that. We have a mental health specialist as well. And then we have a nerve surgeon as well for people who need that work. And so we have them meet with everyone on the team, and we go through and discuss them as a group. We have meetings where we go through as a group and say, these are some of the barriers. We do or do not think this person's a good candidate, and these are the reasons why. And a lot of times we've had patients that have come in and they just have a few things that need done, right? They need to get their diabetes managed. They need to do some weight loss. We've had some patients that were a little bit deconditioned, chronically infected total knee patient, very, very deconditioned. So we did prehabilitation on him, and that's a great thing. And so our team, any member of our team can push pause on a patient going into the pathway, because they see different things and get different information from the patients. And then when everyone says, yeah, let's go, then they get scheduled and we go from there. And so the process is not immediate because, again, this is something that, and it's not just us. As a patient, you need to very carefully select who you're going to work with, because as you saw some of the numbers, there will be challenges along the way. And so if you don't have a team that you feel comfortable that you can reach out to and that is keeping in connection with you, the worst situation is to have a surgery like this and then feel like you're not connected to the team or you've been somewhat abandoned by it. And all of us as clinicians have challenges around communication and different things like that. And so that's why the people who work with me on this are really the most valuable for being able to keep that constant thread with our patients.
And guys, I will say it, it's worth the plane ticket. I know you've had a lot of out-of-state patients come in to your clinic specifically to have the OI done. And you know, if I'll put it just an extra one out there, guys, you know, you're going to find, and if you can't click the QR code, Drew, if you go to the Integrum website, they're going to have a directory there, and they can connect you with a physician. I would even go so far, guys, if you don't have someone who's giving you a personal recommendation, like I am recommending Dr. Hsu directly to you, or you're hearing from another patient, get two opinions. And this is a big step in your life, and it's a big commitment. And it can be a life changer and a game changer. But as we spoke ad nauseum on this show tonight, there are risks involved. So not just talking to this potential surgeon about when things go well, but asking them what happens if things do not go well. What systems and protocols do you have in place to help me through it? And any surgeon worth their salt is going to be able to walk you through those protocols. Jeannie says, I drove over 400 miles to see Dr. Hsu and his team. You got a lot of fans on here tonight. Dana asks one last question. What BMI is considered too high for OI, and do you take muscle mass into consideration? Good question, Dana.
It's a great question. We don't do anything further than a BMI screening. We do an unadjusted BMI of 35. And, you know, people can go back and forth as to whether or not you should do an adjusted and what other things are going to be done. We take everything into consideration, but that tends to be the cutoff that we use, and that's really leveraging the experience from Walter Reed. Their cutoff was 35, and usually patients, you know, we can kind of get them through where they can meet those goals to have the surgery done.
Yeah, and guys, the fact that he has a dietitian on staff and there's pre-rehabilitation, I haven't heard that since I was a student and dinosaurs were walking the earth. So that's pretty incredible.
That's Angela Abernathy, and believe it or not, you know, she's
a rock star.
I think you've met her before.
Oh yeah.
She now has a QR code that Amber, my patient navigator, created for. Angela has a website now with all the exercises and every different things that she's been doing to kind of help with some of this stuff as well. And so I know that's stuff that y'all have in common, or you're doing a lot of the stuff where people can do that at home. And so that it's, you know, that's something that she can share with you as well, that your followership may be interested in.
Yeah, absolutely. No, I'm looking forward to meeting her in November. All right, guys, this has been a great show. So I do want to say a very special thank you to Dr. Hsu for giving us of his time and expertise this evening once again, and also to Integrum for continuing supporting this show and allowing me to have wonderful guests like Dr. Hsu come on board and allowing us to talk about the good, the bad, and the ugly. So thank you again to the Integrum team, and for all of those of you who showed up this evening for support. Thank you very much. As always, guys, thank you for letting us be a part of your lives this evening. I will see you next week, same bat time, same bat channel.